You know that the sodium glucose
Yeah.
transporter is now
Okay.
one of the drugs in everywhere. So we,
It's
we,
for
we have to
sugar.
tackle
Yeah.
that. I would like all first to thank and inviting you to our next week Congress of Nephrology and Hemodialysis chapter. I would like to thank the pioneer and the godfather Professor دكتور ناجي عبد الهادي وهو ان شاء الله هيتكرم معنا الاسبوع الجاي في مؤتمرنا مؤتمر عين شمس. I would like also to thank Professor Amr, Professor Ashraf, and Professor Kamal, Professor Ala Sabri for his kindness and invitation. Uh, Today I will tackle the role of sodium glucose transporter in two parts. One part is the CKD, and the second part is the role of sodium glucose transporters. And this is declaration for my industrial symposium and applied for the Anti-Bribery Act and no offensive material or are belonging to scientific. What about the CKD? The CKD is a class tunnels. If you put in the tunnel, you wouldn't be. If you are asking what is the CKD, what's your first name is Fulan, and what's your surname and family name is CKD. Even after transplantation, you will have a patient is CKD transplantation. So we need to change the line of treatment, and the emerging sodium glucose transporters inhibitor is now. Looking for the first part of the talk, what is the epidemiology and burden of CKD? And chronic kidney disease is one of the fastest growing cause of death, not only on low medium income countries, but as well in high income countries. So the CKD burdens have a lot of complications like premature morbidity, mortality, cardiovascular risk, progression to end-stage kidney disease, and extensive burden financial on the Medicare. And if you look that despite CKD affecting many people, still a little is diagnosed and proportionally unrelated to the patient on the top of the iceberg who are needing renal replacement therapy. So the epidemiology of chronic kidney disease, it's estimated about more than 800 million global worldwide, and this is increasing in the death rate more than 40% of the causes of the death and five fifth cause of death in the near future within few years. Countries are suffering from CKD like in the Middle East and in Latin America and then the Gulf area, probably increasing in the incidence of diabetes as well in this area. The data from the registry in trend excess mortality in Europe, and it shows that although there is improvement in the survival in patient on renal replacement therapy, but still on transplantation is the highest survival comparing that to other modalities of dialysis. So we need to have a health-related quality of life in people who are treating, not only just to maintaining his life. And subsequently, you can see that a lot of improvement we have to do to improve the quality of therapy and the quality of life to those patients suffering from CKD. Still, we have a big gap between required renal replacement therapy and the receiving the service. We have economic needs uh, controlling that to gross domestic products of the finance, service implementation, not all countries have service, and screening and early diagnosis. So the largest treatment gaps occur in Africa, while it's about 9 to 16% only have receiving kidney renal transplantation or dialysis, and in the incidence or prevalence of renal replacement therapy in Africa is the lowest comparing to Europe, Latin America, and America. So the relationship between AKI and CKD, we can find that diabetes is almost present for both probability of acute kidney injury like post-contrast or in chronic kidney disease progression. So this is in part denying that CKD is of one cause, but the major cause is diabetes. Even in non-albuminuric patient with diabetes mellitus has highest risk of progression to CKD and cardiovascular death. So the novel risk for progression of kidney disease, some biomarkers are now coming from researches like NIGAL, urinary albumin creatinine ratio, inflammatory mediators, chemokines, all these in the blood of the patient with CKD can make the biomarkers of the CKD progression. What about the diabetes worldwide on end-stage renal disease and on dialysis? Still in Egypt, we have only 13% of diabetic patients on dialysis, while in USA, it's approaching 50% as usual. In Germany, approaching 40%, and in Gulf area, it's variable, but it's in the range between 40 and 50%. So the global burden of the disease, which estimated the health-related quality of life, as well the years lived with disability and years of life lost. And if you look that for the CKD burden, there is increasing the disability as well the mortality in those patients. And the low-income countries and the highest age standardized disability life years have shown that and concluded that CKD burden remains high in various income regions, not only on low income, but as well in the middle and high income. So in many countries, there is missing or shortage of the treatment. About 7 million are lacking to facilitations and facilities for the receiving the therapeutic challenges in this area is important. The one key is to preventive or to give a drug that prevents the progression. The burden of the chronic kidney disease is increasing rapidly and should aware about that. One of them is diabetes, and it is our talk today. Heart failure and diabetes and CKD are interplaying to each other. How it started, we all know that the progress of the CKD with diabetes, with hyperfiltration, microalbuminuria, developed to frank proteinuria, and finally nephrosclerosis in the stage of kidney disease requiring renal replacement therapy. So we need to bridge the gap between the knowledge based, and here is the sodium glucose transporters. We have to reform that, identify that patient with legacy effect, meaning that if you control the diabetes earlier, it will be the better, and the early intensive glycemic control can prevent irreversible damage, such as epigenetic alterations associated with hyperglycemia. Looking to the what is the interested discussion in cardiovascular calcification, and if you see that both in aging group like glycation classification, and if you put the diabetes as well as the CKD patient, both of them have the same pathway of vascular calcification, differs between medial calcification or atherosclerotic calcification, but at the end there is a potential cardiovascular calcifications and so atherosclerotic disease. The sodium glucose transporter giving the hope of improvement in the cardiac pre and after load, improving the cardiac metabolism, myocardial sodium and hydrogen exchange, and reduction in the cardiac necrosis and apoptosis, alteration in cytokines and adipokines production. On the kidney, we now understand that the tubulo-glomerular feedback control, and this is decreasing the hyperfiltration and synchronized with the ACE or ARBs. As well, it can be work like a diuretic without intensifying hypovolemia or decreases intravascular compartment. So one of them, if sodium glucose transporter, is the dapagliflozins or for SIGA, and it can control the glycemic weight loss as well as the blood pressure reduction. It could be in the latest literature that DABA could be potentially beneficial in many cases in diabetic and not diabetic, as well in the different stages of CKD, stage 2, 3, and even 4 can get benefits. Still, there is questions we may be highlight in our discussion after the end. So the DAPA and clinical program span preventing in type 2 diabetes. There is a clear study, DAPA CKD, and all we know that these all trials had been done few couple of years ago, and they proved that it had been one of the major advances in the treatment of diabetes as well in CKD. So the declare and DAPA CKD is continuously, and it depends on the stages of CKD, the results, and post hoc studies show that there is improvement in the urinary albumin creatinine ratio as well as the progression of CKD, whatever the stage. How to screen? It is simply you can do urinary albumin creatinine ratio as well hemoglobin A1C and the target between 6.5 and below 8% in advanced kidney disease. There is some bias in hemoglobin A1C like in metabolic acidosis and bias low like in anemia or blood transfusion. So frequency, usually hemoglobin A1C at least twice per year and more be many times frequently if the patient has episodes of hypoglycemia. So the KDIGO guideline and its update showing that in the latest commentary that there is a pivotal moment in the DIGO guideline to control and to put the diabetes as one of the target of its guidelines. And here put a lot of issues of controlling the hypoglycemia, lipid profile, exercise, as well to put still metformin and sodium glucose co-transporters, and the meeting individuals should be individualized. So if you can lower glycemic target, we can add sodium glucose co-transporter inhibitor with much education to the patient how to deal with hypoglycemia or any side effects. So the KDIGO recommends sodium glucose co-transporters, not only, but as well with other like blood pressure, lipid, cessation of smoking, controlling of all other metabolic error. And metformin, sodium glucose co-transporters are one of the first line treatment plus GLP-1 when needed and if it is feasible for the patient for the cost. So decreased sodium intake is one of the target controlling blood pressure, but there is sodium toxicity exceeding the hypertension to any others. So we can initiate ACE or ARBs beside sodium glucose co-transporter, but putting in mind that hyperkalemia in ACE or ARB may be limited. If you have an increased 30% of serum creatine at the baseline, you should revise the patient and decreasing as well the dose. A lot of guidelines considering dapagliflozin, including the UK guidelines in the NICE, National Institute for Health and Excellency, as well in the FDA, which approved the recommendation to use dapagliflozin in patients with diabetic and the patient with CKD as a synergistic combination with sodium glucose co-transporter and ACE or ARB. So this is FDA and the DABA significantly victory for CKD with or without diabetes. We know that not all ACE or ARBs have the 100% improvement in the prognosis or the complication of diabetic patients with CKD. However, there is a residual, and this residual could be covered by adding sodium glucose co-transporters to the patient to delay the progression of the chronic kidney disease. The identical studies and the renal studies and the others, we have to put some of the dapagliflozin to the treatment in literatures as well in the patient. So if you look to that, these data in the KDIGO guidelines risk factor, which is severe high risk, meaning that patient with CKD, even type 4 CKD, had got benefits from delaying the progression to end-stage kidney disease. So for XIGA or dapagliflozin, it's synergistic in the hemodynamic changes in diabetic and in non-diabetic, improving the endpoint, primary and secondary endpoint in the cardiovascular, atherosclerotic cardiovascular disease, hospitalization for heart failure, and even in patients with progression of the chronic kidney disease. So reduce the risk of cardiovascular disease, reduce the risk of all-cause mortality, and DABA has demonstrated cardio and renal benefit across a broad spectrum of CKD patients. It is a long way that dapagliflozin may decrease firstly the estimated GFR, then improvement all through the cycle of the researches, time, and this is a prognostic value. So sodium glucose co-transporter as a guideline is implemented early in patients with diabetes and in non-diabetic patients is important, and starting from 10 milligram, this is the dose, regular dose we can approach. And Mr. Chairman and colleagues, what is our take-home message is the CKD is a closed tunnel. The patient will have his family name is CKD, whatever on dialysis or on transplantation. The only way is the screening and to prevent a lot of patients. We have 800 million patients are going up for requiring renal replacement therapy. The dapagliflozin is a solid, informative, and research. We all know that, and it's your own experiences with dapagliflozin in the management of CKD and in diabetes. And for sure, we are still waiting the role of sodium glucose co-transporter, not only for focal segmental glomerulosclerosis, but as well in all other glomerulopathy. Up till now, we don't have sufficient data to prescribe. And thank you very much for changing the light.
Thank you very much, Professor Hisham, for this elegant presentation. I think if we have time for a couple of questions. My first question. Thank you, Doctor. Just a second. Okay, just a second. Dr. Hisham, you clarified very well and very clear that despite all the previous landmark trials of renal protection, including renal and indent and ERMA2, still there is residual risk of progression of chronic kidney disease. And this is a missing gap, actually. This is a potential for use of such medication like I'm just maybe SGL2 inhibitors and GLP-1 agonist or so, maybe fill that gap and they minimize that risk in such patient. So, doctor, please.
Thanks for elegant lectures, my professor. دلوقتي السجلت 2 انهبيتور بتعمل لي الثري شولد الرينال 3 شولد لغايه 120 بتنزله لغايه 120
اللي هو ايه يا فندم معلش
الرينال 3 شولد للجلوكوز بينزل بسبب السجلت 2 انهبيتور الى 120 وطبعا في دراسات قالت 80 احنا خلينا في ال 120
But يعني go to the point please على طول because of the time يعني. Go to the point يعني. Your question and your recommendation.
هو انا سؤالي انه ليه ما بيقدرش السجلت 2 انهبيتور انها كنترول البلاد شوجر في اي رقم حتى لو وصل ل 500 600 طالما هو الرينال 3 شولد خلاص نزل ليه ما بيقدرش لوحده يعمل لي كنترول ولا بد من اسوسيشن لدراجز عشان اعمل كنترول
شكرا جزيلا. In all the guidelines there is no one drug can control of hyperglycemia. We need always a combination of therapy like metformin is basic and sodium glucose transporter. If you don't control, you can go up with, for example, GLP-1 agonist. And so we cannot depend on only one drug to control severe hyperglycemia.
Dr. Hisham, يعني just to make it very clear that this GLP-2 inhibitor, we are not talking about its hypoglycemic effect. We are talking now what's beyond control of hyperglycemia or diabetes. And Dr. Hisham is talking now about another issue, very clear issue. It's not related to diabetes itself, but it may be related to some other
even
non-diabetic causes of
the progression.
Kidney.
Let me change changing the line. As a speaker, I would like to ask the expert on the panel and the expert here. And every day we have cases of heart failure and GFR is, for example, 15. And this is off-label of using Forxiga or dapagliflozin. And you understand that it's maybe of benefits for the heart, not on the benefits or the study for the CKD progression. So is this patient eligible to take dapagliflozin? Patient with heart failure, ejection fraction 30%, with CKD estimated GFR 15 or low, or even on dialysis, but may get benefit from Forxiga on the heart with ACE. Should we prescribe? I understand it is off-label. Your expert.
Thank you very much, Professor Hisham. I just would like to add the answer for this question. It cannot be calculated so simply. It depends on the number of the receptor, affinity of the receptor, other molecules acting on the receptors. So we couldn't take it as simple as it is. This is my answer for your question. Sorry, Dr. Hisham, I didn't get your question. You were asking a question or
We
concluding?
understand that sodium glucose transporter alone is not enough to control hyperglycemia, and this point is out of our scope now. My question, this is my daily practice. If you have a patient with estimated GFR below 25 as rated in the DABA CKD, and still the patient has heart failure, should we prescribe off-label of dapagliflozin or not? هم بقى اللي يديروا. Not starting 25 and the drop. I understand if it's 25 and drop, you should continue. No, if you start below 25 in patient with heart failure. But the effect on the heart is different. Effect on the heart is different.
الامبروفمنت بتاع البلاد جلوكوز ليفل وهيرفلكت على الامبروفمنت بتاع السي دي. لكن الاذر ميكانيزم اوف اكشن اللي حضرتك تقصده على الهارت انه هو بيحسن الميتابوليك والكاردياك فيول والانرجي بتاع الهارت من خلال الميتوكوندريا والكيتون بودز اللي هو بيطلعها، وهي دي اللي بتعتبر المين سورس اوف كاردياك انرجي. دي نمره واحد. نمره اثنين، على مستوى الناتريوريسيس هيكون لازم عندي مينيمم جي اف ار عشان يشتغل كناتريوريسيس ويعمل صوديوم اكسكريشن ان يورين ويقلل اليورين ويقلل الفوليوم اوفرلود. وعلى مستوى السيستوليك بلاد بريشر اللي هو بيعمل ريدكشن برضه لحوالي 3 ل 5 ملم ميركوري ريدكشن في البلاد بريشر. كل دول هيحسنوا لي البرفورمانس بتاع الهارت بياند الجلايسيميك كنترول وبياند السي كي دي بروتكشن. لكن هو محتاج مينيمم جي اف ار يشتغل عليه. علشان كده كل الجايد لاينز قالت ان هو مش هيستخدم على الدياليسيس بيشنت، ويمكن كان اخرهم الجديد جايد لاينز قالت العين على دياليسيس ستوب. This is my opinion.
ايفن لو الايجكشن فراكشن اقل من 30 او فوق ال 30 انا ما ابداش. ده بالنسبه للاتش جي ال 2. يعني هو عشان ابدا محتاجين جي اف ار اكتر من 25 ايفن حتى ولو انا عندي ايجكشن فراكشن قليل. ولكن لو انا بادئ وسي عندي جي اف ار 30 35 والجي اف ار دروبد بيلو 25 I will continue.
Thank you, Dr. Hisham. Actually, I have one comment. When I read SGLT2 inhibitor in management of chronic kidney disease, I will be anxious because I feel that it will be translated to a message that we should prescribe these drugs for our patients. And actually, I am not feel ease with this situation, and even I wonder every patient with CKD I can give dapagliflozin. Any CKD due to glomerular, tubular, interstitial or tubulo-interstitial disease, any patients with renal stone disease and recurrent UTI, it is very crucial to define who will get benefit from this drug. Otherwise, it will be a problem.
طب تاني برضه نفس الكلام برضه عشان نأكد ان احنا بقصة ان هو الكيديجو بتقول ان احنا we can use it until 20 milliliter per minute. Is that right? 25. What am I going to preserve الكدني ولا أنا I'm looking for something else. دكتور عمرو، دكتور أشرف، هو أنا بعمل ده عشان أبريزيرف؟ طب is there any longitudinal studies in those patients for renal protection and the preservation of the kidney function? And this is for my dear respected colleagues and professors, just to to think loudly a little bit. Does it worth just to expose Dr. Ahmed Adam? Does it worth to expose the patient to the risk? Still, it is a risk. So we have to weigh the risk and the benefit. And we just are thinking about only guidelines. And guideline, does it fit all? If I'm using SGL2 for 25 milliliter minute or less, and for the sake of preservation of the kidney function, on an expert opinion, does it worth just to expose my patient to that risk?
I think Dr. Tariq Elbaz has a comment or can answer this question. Can you give Dr. Tariq the microphone, please? Then we'll close this session.
Regarding which type of CKD, no one looked into this type of classification of patients and whether the DAPA CKD trial or the EMPEREC trial. It was broadly speaking CKD, whether it's due to glomerulopathhy or diabetic kidney disease or whatsoever. Because simply, what is SGL2 doing in this situation? It's got nothing to do with the receptors that may be not functioning anymore. صح يا هشام? They'll not be functioning anymore in this low GFR, but rather you are gaining the benefits through other mechanisms beyond those that described when the drug was first discovered, related to blocking the receptor. They have other modes. I don't want to go through the details of how they function as antioxidants and so forth, and antifibrotic as well. So this is how they function. So the concept of using them to which level of GFR, every couple of years so far it's going down. And I was in a meeting last year with the president of the Royal College of Physicians, and he advised to use it up to a GFR of 20. Mind you, measuring the GFR is fallacious, even if we are going to use the new formula now, still fallacious. So you have to take care about this. Regarding the caution, which patient you should be choosy and you should individualize this drug, just like individualizing any other drug. I'm not going to give it to a patient who is prone to ketosis with an advanced heart failure, who is diabetic, who could develop ketosis. I'm not going to give it to an elderly patient who's not drinking enough and he's already having a sort of hypovolemia for fear of dehydration, if he's still got enough renal tubules. So you have to choose your patient just like any other medications of this form to avoid such risks as dehydration and ketosis. But you're not talking about the function of renal tubules and SGL2 inhibitor at this point. You're talking about beyond this, and this is what you've been saying. You have functions beyond the glycemic control. I don't know if I answered the questions or not.
Thank you so much, Dr. Tariq. Thank you so much, Dr. Hisham Said, for this excellent presentation. I think you are